I think we all have these patients, the cytopenic versus myeloproliferative myelofibrosis, although the title is cytopenic patients in MPN, but I think we all agree that it is mainly patients with MF. And, the publication that appeared 2 years ago has really nicely described that this group of patients is actually a different, not only clinical, but also genetically different subgroup of patients with really worse prognosis. They usually have, in addition to the low counts, more fibrosis, mainly primary MFs, more blasts, high risk scores. They have certain somatic mutations, low allele burden of JAK2, and as a consequence of all these differences compared to the myeloproliferative MFs, I think these patients will agree to have limited treatment options and a much worse prognosis compared to the standard myeloproliferative MF. Next slide, please. So I thought maybe we could discuss these options. What do we have for these patients? Allogenic stem cell, the so-called supportive, JAK inhibitors, and then maybe a look to the future investigational agents, some combinations in these patients. Next slide. I just always, we always forget the option of allogenic stem cell transplantation in the era of all these new clinical trials. And so I think if the patient is younger, although these are only a very few patients and there is a suitable donor, I think allogenic stem cell transplantation is really one of the very good options for these high-risk patients. Next. Supportive. I didn't know what I should call supportive. In addition to transfusions, I included under supportive the medications, the drugs we have been using for the last 20 years, actually, in anemic thrombocytopenic patients, particularly in the pre-JAK inhibitor era. But still, we are finding them very useful in one or another of these patients, like erythropoietin, the immune modulators, with, pomalidomide, the only drug that has a phase 3 trial, androgens, all these drugs have been known to be used, and really, they are very helpful. And sometimes, we have these severely thrombocytopenic patients, and we do forget that thalidomide might be cheap and might be quite effective, or a danazol treatment in these patients. Next group are surely the JAK inhibitors. And now next, please. We have our classical with a big phase 3 clinical trial data is available. And, looking at, ruxolitinib, fedratinib that are approved almost all over the world, we could use them without a problem in patients with platelets up to 50,000 and higher. Momelotinib is coming soon, where we could treat patients with anemia plus platelets as low as 25. And we surely have pacritinib, which is approved in the United States and not yet in Europe or rest of the world, which is again a very interesting drug, particularly for patients with very severe thrombocytopenia as well as anemia. Next. Just a very quick overview. We all are aware of ruxolitinib and the issue, in patients with the so-called moderate thrombocytopenia, 50, 60,000, where we usually standard per approval and prescription use low doses of 5 milligram BID, and expectedly we know that the response in these patients is not that as good as in patients with higher doses, and this is all well known. Nevertheless, I believe that if we have patients having moderate thrombocytopenia, low dose ruxolitinib is still an issue. The next is fedratinib. Can you go to the next? But at the bottom line, in clinical practice, we see that transfusion dependency and thrombocytopenia, actually platelets below 100, are still the major reasons why ruxolitinib is discontinued. And I believe, and I think what is important and what we have to discuss is when we talk about cytopenic MF and treatment options, I think we should always emphasize the fact that it is thrombocytopenia that should guide us rather than anemia, because we are all aware of the data of JAK inhibitors, particularly ruxolitinib in anemic patients, and that it might be very useful even in these patients. And we have learned over the last several years to deal with anemia very well. But indeed, I think transfusion dependency and severe thrombocytopenia remains a challenge. in treating patients with adequate doses of ruxolitinib. Next slide, please. Yes, fedratinib. I think MF-related anemia is not a good argument for choosing or preferring fedratinib over ruxolitinib, because we know, although there is no head-to-head comparison, the incidence of anemia in both Jakarta trials was similar to that what we know for ruxolitinib. So anemia is not really different whether I treat a patient with fedratinib or ruxolitinib. But next slide, please. I think maybe one major difference is the incidence of thrombocytopenia, particularly in patients with MF-related thrombocytopenia, as although the numbers are small, we know, particularly in the Jakarta trial, first-line treatment, that for patients with moderate thrombocytopenia between 50 and less than 100, fedratinib, even with a full dose, might be given to these patients, and the incidence of grade 3 or grade 4 thrombocytopenia is less. Again, no head-to-head comparison, but nevertheless, it's quite less than that what we know from ruxolitinib. And this is also the clinical experience. So it is easier to manage these patients, and maybe with the higher dose, we could give these patients, we might have better responses, but unfortunately, we do not have head-to-head comparisons, and I think we will not likely have them. Next slide, please. Yes, so the summary, as I said, I think it is an thrombocytopenia rather than anemia, although we always have these discussions with our colleagues because anemia seems to be a concern in many physicians in everyday practice, and we always try to persuade physicians not to look at anemia that much, but more than platelets, and platelets should guide us. And the close monitoring, surely, in these cytopenic patients is quite crucial. And just as a small remark, I think we could include ESAs, particularly if we bridge the anemia caused by ruxolitinib. We have a lot of data to that, but in the majority of patients, we don't really need to use ESAs in combination with ruxolitinib or fedratinib. So the next slide is, what about momelotinib? We all are aware of the phase 3 trial, Momentum trial, which compared momelotinib to danazol in mainly anemic patients below hemoglobin below 10 grams per deciliter and platelets as low as 25%. These data were presented at ASCO, at EHA, and the paper has been accepted for publication, and I hope it will appear soon. And on the bottom line, it is no surprise, momelotinib was superior to danazol in its primary endpoint, the total symptom response. But what is interesting, I think, is also the transfusion independence, which we could expect in around 30% of transfusion-dependent patients. And also the spleen reduction is well comparable to other second-line treatments like fedratinib or pacritinib. But I think the transfusion independence is quite interesting. If you go to the next slide, please. At the last EHA, an update of 48 weeks was presented, ASH was presented. And again, if we look at the baseline characteristics of the patients at the time of inclusion into the trial, the majority of these patients were actually transfusion dependent, with only 13% being non-transfusion dependent. And if we look at the results at week 48, next slide, please. I think that they are not bad, as we said, around 30%. But I think this subgroup analysis, although the numbers get smaller, based on the baseline platelet count, again shows that momelotinib could be a good option, even for patients with low platelets below 50,000, and particularly in those patients having moderate thrombocytopenia between 50 and 100. And the responses were maintained in the majority of patients up to week 48. I think these data are quite encouraging. Momelotinib is now, submitted for approval, and I hope it will be available as a second treatment option, particularly in these cytopenic patients. Next slide. Yeah, and the incidence of thrombocytopenia, despite the fact that the majority of patients had low platelets, was not that high. Nevertheless, we do not have to forget that we still get grade 3 and even more than grade 3 bleeding episodes and cardiovascular events. So still close monitoring of all these patients is quite necessary. Next slide. I think just a few words to the last or the fourth JAK inhibitor, pacritinib, which is approved in the United States. And we know that at last EHA presentation was very interesting regarding all the patients with very low platelets, so the median platelet count of 30,000, even with 20% of them being transfusion dependent. And the safety data of pacritinib in this patient subgroup was presented. And I think it is really, pacritinib is really a drug for patients with really severe thrombocytopenia, even if they are transfusion dependent. Nevertheless, if we look at the incidence of the grade 3 and more severe bleeding episodes, as well as cardiovascular events, I think, again, no head-to-head comparison, but I think they are quite comparable to that, what we know from the MOMENTUM trial for patients treated with momelotinib. Next slide. And at this edge, the transfusion independence for pacritinib patients treated in the PERSIST 2 trial who were transfusion dependent were presented. And again, all of these patients had platelets below 100. And I think that these data just confirm what we know, and that again, pacritinib has a tendency to induce transfusion independence, and similarly to that, what we know from momelotinib. Next slide, please. And the authors have very nicely shown that, again, similar to momelotinib, pacritinib has two non-JAK target, namely the activity on the activin A receptor type 1, which, as we all know, is a bone morphogenic protein receptor kinase that regulates hepcidin expression. So I think these are quite encouraging data, and we hope that we do get an approval in Europe someday for pacritinib. Next slide. I'm almost finished. I think just a small look to the future. Luspatercept in combination with JAK inhibitors, ruxolitinib, fedratinib, particularly JAK inhibitor-induced anemia and transfusion dependency, seems quite a good indication for combining luspatercept, the TGF beta signal pathway inhibitor, with one of these JAK inhibitors. And we all know that the independent trial is ongoing, where JAK inhibitors and luspatercept or placebo are being tested in transfusion-dependent patients. And we hope that we get some results soon. And maybe this is another option, particularly for transfusion-dependent anemic patients. The final slide is, what is coming next. We know that we have other selective JAK2 inhibitors, for example, an SCO18 ilginetinib, which again showed in the first data quite promising results in severely thrombocytopenic patients, first and second line, and we will have soon the phase 2 trial also in Europe that is really randomizing patients with severe thrombocytopenia to ilginetinib versus best available therapy. And with this, I come to my conclusions. I think we have a very busy time now, very nice opportunities for many patients. For those with no or mild cytopenia, platelets above 100, we really do have a lot of options, a lot of investigational agents, combinations. This gets less as with every step of reduced platelets. Those with moderate cytopenia, we still can use low-dose ruxolitinib, we can use fedratinib, pacritinib, momelotinib might be options, and there are some investigational agents. But for those with severe cytopenia, I think the issue becomes narrow. I think allogenic stem cell transplantation, if feasible, should never be forgotten. And then pacritinib in the United States is a real option for these patients. We hope that we will have momelotinib soon too, and then the few investigational agents. And with this, I would like to thank you very much, and we'll be happy to have a discussion. Thank you.